Hello, everyone. It's great to see you all, and I'm really excited. We've been here in Brno, sorry for my pronunciation, for about a week now, and I'm happy to say I actually see some familiar faces, so it's good to see you all. Thank you so much for inviting us, and especially me. I feel like I kind of weaseled my way in here. McCall and Jakub, our friends and colleagues, but I was able to join also, so I'm really excited to be here. And yes, I am the sociologist of this talk. So I'm going to be giving a perspective of health equity and population health from a single sociologist perspective. I don't want to claim I'm speaking for all American sociologists, far from it. People familiar with the field know that there's lots of different ways that you can use sociology to look at lots of different outcomes, including health. But this is insights from me as a sociologist working in the US. So the topic of the presentation today is population health and health equity. So I'll give just a brief description of those two phrases. So you can probably guess from population health, it's not too tricky of a concept, but the idea is you're looking at the health of a group of people, and you can define that population however you want. It can be a population of a country, population of a city, of a school, but the idea is just this average kind of a health outcome of a group of people. Whereas health equity is really looking at differences in health between different groups, and differences that are really rooted in justice or fairness, and based on distribution or unequal distribution of resources and opportunities. So you can see here, hopefully in this graphic, that the idea is these two children in the top left for you, there's inequality, right? One of the children is getting an apple just because it happens to fall where he's standing. So an equality approach to this problem would be to give the two children on the bottom left a ladder, the same resources to achieve the same outcome. However, we see here they're not actually achieving the same outcome, right? The child on the left is able to reach the apples with that ladder, whereas the child on the right is still unable to get that apple, despite having the same resources as the other child. So equity, I see it used as a way of talking about these health differences, but also as an approach to addressing these differences. So equity is an approach where you're going to meet the people where they're at. You're going to give the people who have fewer resources more resources to then be able to have the same opportunities to have, in this case, good health. So those are the two broad concepts that we're discussing today from slightly different perspectives. And so a sociologist generally approaches this topic of health equity by focusing on the social determinants of health. And when I say social determinants of health, I mean the social and economic resources or factors that contribute to our health outcomes. So things like economic stability, our employment status or our income level, medical bills in the US context, neighborhood and physical environment, so things like your quality of housing or your access to transportation, which I keep telling everybody, I'm loving your transportation system here. I wish we had it in Atlanta. Our education level, so things like health literacy and your early childhood education, building that knowledge and allowing you to be able to figure out, how do I practice health behaviors? How do I problem solve and figure out how to make it work for me? Of course, food is a really important component of health, so thinking about access to food, but especially healthy food. Community, safety, and social context. So something that sociologists have been studying for a long time is our concepts like social integration and social networks. So even isolation can have a negative effect on our health. And then finally, access to the healthcare system, which McCall will talk a little bit more about than I will. But these are all factors that I think, it's hard to think back what I thought before I started studying this, but you can think they're kind of removed from our individual level health outcomes because they're not things like our genetics or healthcare treatments. But over and over, research has shown that these social determinants are really important for our health outcomes. And in particular, they can really stratify us along these social dimensions in terms of our health outcomes, creating health inequities. So this chart is from a study that was done in the New England Journal of Medicine a good amount of time ago, but it quantifies these different effects that, or the different factors that go into premature death calculations. So generally, you can think about this as health outcomes in general. So you can see that the genetic predisposition in healthcare actually contribute not even half the amount of of factors that contribute to premature death. Whereas components that I think of as social factors, especially social circumstances, environmental exposure, and behavioral patterns, are contributing more than 50%. So there's just a lot of this research showing that these social factors are really important to consider when we're describing health equity and also trying to figure out solutions to close those gaps in health outcomes. So this is just one example of a health inequity that researchers have been looking at for decades, is this education gap in health outcomes. So this is a chart of gap in life expectancy at age 30 between the highest and lowest levels of education. The darker, maybe you can't see it super well, but the darker diamonds are the gap in life expectancy for males. So you see all the way on the left, Slovak Republic, the gap is 15 years for men between expected life expectancy for the high and low educated. And of course, over and over, we see the higher educated have the longer life. So this means that men in the Slovak Republic live about 15 years longer if they have the highest level of education compared to men with the lowest level of education. And I just pointed it out because it was all the way to the left, but we see here is the OECD average, and Czech Republic is here. So the gap is bigger for men than the OECD average in the Czech Republic at about 10 or 11 years for men between the highest levels of education, highest and lowest level of education. It's interesting, women actually, there isn't as big of a difference. It's one of the countries with the smallest gap and about 2 or 3 years of life expectancy difference. So that's just capturing one statistic about life expectancy based on your education and gender. So what sociologists like to do is we have this thing called the sociological imagination. We like to put things into historical context or thinking about the social structures and how that impacts our individual characteristics. You know, why do people with lower education tend to have poorer health? Is it just because they're making poor decisions around their health? I think a lot of sociologists would say, no, that's not true, that they're making these decisions in the context that makes it more difficult for them to make the healthy decisions. So this is, if you remember the container ship stuck in the Suez Canal, there were all these memes that came out after it happened. But the idea here is that this tiny little truck is trying to push this canal out and free it. So that's how I think sociologists think about these are our personal decisions up against these huge structures that are constraining choices and opportunities based on your social category a lot of time. So both are important, but they work together. So one example here that I pulled is a study from the Czech Republic. I don't know the context as well, but I tried to look up some of the research that was being done here that it's on neighborhood level, neighborhood advantage or disadvantage in relationship to these 4 health outcomes on the left. So obesity, hypertension, smoking, and physical activity. And so I just mentioned education. One of the ways that there's lots of ways that education can impact our health. One of the ways is through its association with income and our access to material resources, the ability to buy healthy food, for example. And another way that it's education and income are related to health is through our neighborhoods. Again, I'm not quite sure about the Czech context, but in the US, our neighborhoods are really segregated by class and race, especially. And as a result, our neighborhoods are really important structures that provide opportunities for good health or make it more difficult to have good health. And so they're important considerations when thinking about social factors in health. For example, some ways in the US at least, the more disadvantaged neighborhoods tend to have fewer green spaces, fewer opportunities to safely get some physical activity. They tend to have more exposure to pollution. They also tend to have more advertisements for cigarettes and alcohol. So that's a structural situation. If you're living in those neighborhoods, you might have more exposures to opportunities to practice unhealthier behaviors than if you lived in a more advantaged neighborhood. And so that is what this study found too in regards to at least smoking. This final column here on the right, you can see on the bottom that they're measuring neighborhood advantage and disadvantage by unemployment rates. So the highest unemployment neighborhood, you're more likely to smoke compared to the lowest unemployed neighborhood. So it's kind of tricky, but the lowest unemployment is the more advantaged neighborhood. The highest unemployment is the least advantaged, the most disadvantaged. So you're more likely to smoke in the most disadvantaged neighborhood. And this model is controlling for these individual level factors, including education. So even if you have a high level of education and you're living in a more disadvantaged neighborhood, in this study, they found you're more likely to be smoking, or you're more likely to smoke, which can, of course, we all know, negatively impact your health. So that is sort of just a broad view of how we're thinking about social determinants of health and structures. This is a little more relevant to my particular research, but sociology and social epidemiology research also in particular, we're really starting to look at macro level factors on these social determinants of health, things like policies. And so this is a conceptual framework that's probably impossible for you to read. I'm sorry about that. But this is a framework that's showing on the left are social conditions. So it says things like employment status, occupation, family income. And then these are the pathways that they're impacting health. So our family income can impact our environment, which then impacts our health, or our health insurance access impacts our behaviors, which then impacts our health. So this is sort of the more traditional social determinant of health approach. But what people are looking at now is taking a step back and looking at these macro level factors, the shipping container factor, and thinking about policies that are then shaping these social conditions. You know, the social safety net in America is really pretty weak compared to European countries. So this is a really important factor that we have to look at. People are calling these causes of causes, and even sometimes causes of causes of causes of health, and particularly health equity. Because if we think about something I study a lot in my research is the welfare program, so the cash assistance program for people who are low income in America. And so if you think about how generous that policy is, that's going to affect people's level of income, especially the low income families in our communities. And then that level of income that they get combined with other sources is going to affect their ability to practice health behaviors. So you have to make some jumps, but I think it's a really important consideration that people are researching a lot now. So just some final conclusions about this type of research, and also the things that we need to continue to do this type of research is that, so I just mentioned that my research and a lot of other sociologists and social epidemiologists are doing research on these social and economic policies and how they affect health through their effect on social determinants of health. And what we're finding over and over is that these policies that are really centered on equity or being more generous in their policies and the programs that they're offering, the resources that they're offering to people, they're having positive effects on people's health. An important consideration that people are turning to now that we've looked broadly at just, was this policy implemented? And if so, how did that affect health? Is thinking about the particular policy elements. This administrative burdens term, for people who haven't heard it yet, is, I think, a pretty hot topic in the field right now because, in a good way, people are excited about it because they're seeing results that really restrictive burdens placed on people who are trying to access these policies, again, like the cash assistance program, people are having to sort of jump through hoops to be able to get the benefits. So people are starting to study these hoops in a more colloquial way, or administrative burdens to understand, okay, what policies do we want to implement, and how exactly should those policies be implemented to achieve overall population health and close those health gaps that I mentioned. But we really need two important things in our work, and that is strong public data infrastructure. I use a lot of larger secondary data sources that are wonderful, but we need more. And I think that this really became even more clear to me during COVID, because they weren't collecting the social determinants of health, at first at least, when they were collecting data on COVID. So we weren't able to fully understand what was going on in terms of health equity. We had to you had to figure out neighborhood zip codes and do a lot of proxy measures to understand health equity in terms of COVID. And also, we need more funding for our public health research. Our funding in America is cut by the government pretty frequently, which means fewer researchers are getting the funding to be able to do this research. And so I, of course, am advocating for more funding so that we can have more projects and more innovative projects too, I think, to be funded, and especially funding for research done about these disparities, these health inequities, and particularly structural conditions. So that's it for me, and now I'll turn it over to McCall.
Wonderful. Right. Dobrý večer. I'm so excited to be here in this wonderful space with this amazing audience. It's so lovely to see this room packed. My name is M.Horný. I'm an assistant professor at Emory University, and I'm going to spend the next 15 minutes, more or less, talking about how health economists think about population health and health equity. Perhaps let me start with this empty slide to illustrate why population health is of interest. Like, who cares or who has interest in population health, besides the fact that a population consists of individuals, and it's fairly natural to think that every single one of us cares about our own health. But why would policymakers why should they care more about population health and not only about the health of individuals in the society? So for individuals, it's pretty straightforward. The sort of like higher level of grouping of individuals are families, and it's pretty straightforward in this case as well. We typically care about our loved ones, our closest family members. But then, like, the next level are employers, and employers also care about health of their employees. They hire them to be productive, not to be sick. And so for employers, it's really important that their workforce is healthy and therefore can do the job they were hired to do. And then finally, at the highest level, at the societal level, it's essentially this concept generalizes to the society as well. For governments, for policymakers, for societies, it's important to have a healthy population, because not only a healthy population does not need as many resources from the social systems, social support systems, but also can be more productive, contribute more to general welfare, contribute more through the work they do. So focusing on population health is important, not only because population consists of individuals, but because it benefits, the benefit multiplies. Now I want to spend a few minutes, maybe a minute, on talking about like what do health economists do. If you notice, I keep calling myself health economist, not economist. Health economics takes concepts from the general economics, the field of economics, but there are certain health is just such a specific kind of a good that not all concepts from general economics apply here. For example, health is perhaps the only, or healthcare is the only service that you can buy while unconscious. if someone can give me another example, I'd love to hear that, but I haven't come up with a single one. In healthcare, also there's huge information asymmetry between the patient and the provider. The patient typically seeks help because the patient herself doesn't know what is the best approach to address their healthcare needs. The healthcare provider does know that. But the healthcare provider is also the one who not only provides the services, essentially sells the services, but demands those services on the patient's behalf. And in this case, that's quite a market imperfection when the seller is also the one who demands services on the patient's behalf. And so one thing that I wanted to mention is that when people say health economics, a lot of people imagine that it's all about prices and costs. How is it worth to spend that much money for this amount of health benefits and so on? And that is certainly important, but health economics is not only about that. It's of course prices and costs are important quantities that we health economists study, but it's not the only thing. Economics in general is about effective allocation of resources. And money, sure, is an important resource, but there are all other kinds of resources that we need to think about how to effectively allocate them. One of them that applies to every single one of us is time. It doesn't matter if you're the richest person on earth or not. We all have 24 hours in a day. It's a limited resource that we need to think about how to allocate. And this is what economists do. We think about how to allocate resources effectively. So having said that, of course, I'll now talk more about cost and spending. On this chart, the horizontal axis shows healthcare spending per capita in various OECD countries. And on the vertical axis, we have life expectancy. It's essentially like the ultimate health outcome. And you would expect that with more spending, we should achieve better health, longer life expectancy, right? And essentially what the arrows show is they show changes in the relationship between spending and health, life expectancy over time. Czechia is highlighted in the boldface arrow, and before I get to that, overall, it seems that this relationship holds. That the more we spend, the higher health or the better health we can achieve. In Czechia's case, there is somewhat concerning trend in recent years. It's not only COVID. It seems that Czechia is going in the direction of higher spending but worse health outcomes, and that is definitely important to study. In general, this relationship, essentially more spending, translates to better health outcomes. Is most likely driven by technological advancements. We have all these new scanners, new technologies, new pharmaceuticals. They extend life. They buy better health, and therefore then we see that in the health measure. But also, think about potential reverse causality here. If we live longer, that will eventually translate to higher healthcare spending. So it's not completely clear, in which direction this causal relationship holds. Having said that, while it certainly holds that over time we tend to spend more on healthcare and achieve better health outcomes, at a more granular level, it seems that the relationship is in a sense reversed, at least in the US. In healthcare markets that spend more on healthcare quality metrics are worse. This relationship is pretty shows a pretty strong negative association, where spending is on the horizontal axis and healthcare quality is on the vertical. And this somewhat suggests that more healthcare spending does not always mean better health, because there can be inefficiencies in that healthcare system. You can think of an example can be poor coordination of care. If we have a patient with certain healthcare need, and the care for that patient is not coordinated well, the patient receives, the same CT scan multiple times from various kinds of providers. That's not going to help that patient's health, but it will increase healthcare spending. So we really need to think how to allocate resources, expenditures, and other kinds of resources effectively in order to achieve better health outcomes. One way how policymakers have been doing that in the US, in many other countries in the world, is in recent years, is by incentivizing high-value healthcare. Historically, in most countries, healthcare has been paid for essentially, in the US they call it fee-for-service, essentially payment for volume. Each additional provided service means more revenue, more money for the healthcare provider. But when we incentivize volume, more healthcare, what we're going to get is more healthcare, but that doesn't necessarily translate to better health outcomes, which is the ultimate goal, right? And so in last, let's say, 2 decades, we see a major shift of international healthcare systems shifting to value-based payment models, essentially tying healthcare spending to quality metrics or to outcomes, better outcomes, better health outcomes of the patients and of the population as a whole. But now I'm finally getting to the importance of health equity. Initially, these models focused on high quality care, better patient outcomes, but didn't really think about quality, didn't incorporate equity. I'm sorry. The models did not consider equity as an important dimension to focus on, which then led to harm to not only patients, but also to healthcare providers. If you think about it, if healthcare providers are incentivized through payment mechanisms to achieve certain level of health outcomes, and if they don't, they get a penalty. Now think about Emily's slides. Healthcare contributes about 10% to health outcomes. All other, like the rest of health comes from other factors, the neighborhoods that we live in, the social contexts, policies, and so on, that's not within the reach of an individual. And so these value-based payment models, without considering equity, were then harming healthcare providers, because those providers who were providing good care, like that they were doing the best they could to disadvantaged populations, they had a much harder time achieving the desired health outcomes. And then they ultimately received a penalty, which essentially means that those individuals, those patients, the disadvantaged patients who needed the resources to get better, were not really getting that because their healthcare providers were even penalized. They not only did not receive the resources needed to achieve the desired health outcomes, they even received the penalty. So with this, I just want to highlight the importance of considering equity when designing payment mechanisms to achieve population health. The previous slide focused on what we economists call the supply side, healthcare providers. But economists also think about how to make healthcare more efficient by incentivizing, that means either promoting or providing some rewards, or penalties to patients for using care in the way that's more appropriate or less. So patient cost sharing is a popular mechanism how to steer patients from not using low-value care and ideally using high-value care. We've had an attempt of that in Czechia about 10 years ago when typically patients pay 30 Czech crowns per visit. That model was very simple, easy to understand, easy to predict. That amount itself was not excessive, in my personal opinion, but it can accrue to levels that may not be affordable for some. So these models that are simple and equal in a sense. Everyone paid 30 Czech crowns, so there was a lot of equality in the exposure of patients to costs. That may ultimately lead to some problems with equity, because what is for someone so-called, in the US, sometimes people call this skin in the game, for some can be unaffordable amount that can then lead, that can prevent patients from accessing needed care. In general, there are many trade-offs. There are so many ways how to design patient cost sharing, how to incentivize patients to use the care that policymakers think is right, or to achieve equity, to give the resources to those who need them, versus and not so many to those who don't. But the problem is that it's really difficult to actually implement that. Like, how do we, at the point when care is consumed, how do we decide, or how do we measure who is at risk, who should receive the additional resources, or who should benefit from easier access to care, versus those who don't really need that extra help. In the US context, patient cost sharing, there's a lot of equality in patient cost sharing. Patients, for example, face the same deductible. That's this amount that patients have to pay for their care before their insurance even starts paying for healthcare services. The level of a deductible is the same for a CEO as for a janitor in the same building. So in that sense, there's a lot of equality, but not equity. For the CEO, the amount of the deductible is really not a big deal, while for lower income individuals, that can be prohibitive. And so in that sense, like these equal systems or equal cost sharing mechanisms, they're blunt instruments, but then like the trade-off is that they can lead to inequity in access to care. The alternative, that's the squiggly part of the slide, can be health insurance mechanisms called value-based insurance design. The idea behind value-based insurance design is to put a lot of burden on services that are of low value, while remove the burden from services that are of high value. A high-value service is, for example, insulin for someone who has diabetes. There's typically no moral hazard. Like, those of you who don't have diabetes are not getting insulin just because you can and because it's free. But for those who have diabetes, it's a life-saving drug, so it's extremely high value. On the other hand, for example, getting an MRI for someone who's in their late 20s and they have lower back pain, it's most likely because they're sitting at their computer all day long, and giving them an MRI may not be the most effective or efficient use of resources. And so that could be an example of a low-value service that is in value-based insurance designs would be considered low value, and therefore there would be a higher cost-sharing level imposed on that service. The problem is that once someone has to decide what's a high value, what's a low value service, and there can be a lot of complexity in the system that can eventually get too difficult to navigate for patients, exposing them to substantial administrative burdens. With this, I feel that I should move on. I also want to briefly talk about equity versus efficiency in the allocation of healthcare resources. Please take this map as just like an illustration. I'm not suggesting that hospitals in where the red crosses are should be eliminated, but this is a hot topic, I believe, in Czech Republic right now. Czech Republic has the highest density of hospitals in Europe, or one of the highest, which is great on one hand. Access to care is fairly easy, especially for individuals who live in rural areas, but that comes at a cost of efficiency. It's more expensive to run a hospital that doesn't have the volume of patients, because the staff still has to be there, even if the patients are not. And there will have to be difficult decisions to be made to find what is the right level of allocation of hospitals throughout the country, so that we preserve as much as equitable access to care, while acknowledging that the current density may be unaffordable, is inefficient. So with this, let me quickly conclude. Health economists focus on effective allocation of resources. That is all we do. It's not always about prices, about costs, but those are important quantities that we typically use as proxies to measure effectiveness. The objective needs to be to maximize both population health and health equity, even though there are trade-offs. Sometimes, to achieve population health without focusing on health equity, perhaps can be achieved easier, but the equity concerns are real, and there are trade-offs, and we will have to decide, what is the right decision in that case. It's a complex problem. It's something that cannot be decided just by a gut feeling. We need evidence to measure, the levels of inequities, the level of efficiencies in the production of health. But to do that, we need high quality research. And that's why I'm so excited that Masaryk University now has a wonderful center for health economics research led by Dr. Hlávka. And this is so incredibly important, because if we don't have evidence, we're just the alternative of not using evidence is making decisions based on no evidence, and those will lead to suboptimal decisions. So it's really important to do research, and I'm so glad to see that Czech Republic is moving in this direction, that finally we will have a strong body of evidence to make informed decisions about how to allocate resources in healthcare to achieve both health equity and population health. So with that, thank you so much for your attention, and we will move to the discussion portion of the lecture.
Since you are a Czech-American couple, my first question is actually about how you perceive the debate on equity. I think coming from the Czech Republic, a lot of people assume that healthcare here is equitable and that we have equal access to all the services, and therefore we should not worry. And yet what Emily has shown is that there is quite a big difference in life expectancy and all that. In the United States, on the other hand, we see huge differences in life expectancy, but the gradient that you showed was actually not as huge. So even when we use different metrics, different indicators, we see that we get very conflicting kind of messages. And so I'm curious if you think that we can even have a social agreement on how much equity do we want and how should we actually get there, or can we get there? So I'm just curious if you can comment on perhaps the Czech-American perspectives here.
Sure. I mean, I'm so hesitant to comment because I do know so little about the Czech context besides what we've talked about. But yeah, in general, I definitely have that perspective that in Europe you have a much stronger social safety net than we do, and that people seem to have better opportunities for good health here. But like you said, there are still inequities, and it's something I've been thinking about a lot because I study these social policies and these safety nets and really feel strongly that they're important for health equity and for good population health. But there's some evidence, for example, that in the Nordic countries, which I think are considered, really as equal of a society as you can get within at least a Western context, they still have pretty high health inequalities too. So that's sort of this Nordic paradox that we hear about, and there's been some research on it. So now people are trying to figure out what's going on there. We thought, providing these strong social safety nets was the answer, but I think it's obviously complicated. As you were talking about, health is not just a simple resource that we can buy and trade or anything. There's a lot of different factors going into it. So I think the next step that I'm seeing more of is that people are taking into account these policies, the administrative burdens that I mentioned, as well as the context. So I do some research on gender and health and thinking about these policies that are aiming to achieve gender equity in economic outcomes and health outcomes. Why are they not achieving gender equity? I know you have a much better maternal paid leave here. We have no guaranteed parental leave at all in the US. But I've heard anecdotally that there's still, of course, gender issues, even with policies that as a US I perceive as the way to go to achieve gender equity, at least in those terms. But thinking about these policies also within the context of the geographical boundary that we're in. What is the relationship between ideas of sexism and how does that interact with maternal or parental paid leave? So I hope that answers your question, but I think social policies are a great way to start, but they're not the 100% answer.
Okay, I'll add a few more thoughts, though not as deep as Emily had. The main difference, in my opinion, when thinking about health equity, like the differences in approaches to health equity between the US and the Czech Republic is like you have to acknowledge, the absolutely different history, the culture, and even the sheer size of the country. Czech Republic is half the size of the state of Georgia where we live, and that's just one of 50 states. And on the other hand, I feel that the issues of health equity have been recognized in the US, and now the policymakers really are incorporating the equity angle in design of new policies. And with that, I'm trying to say is that by ignoring this angle, it's impossible to reach health equity. It's important to acknowledge that that equity is necessary to achieve the highest possible level of population health, and therefore resources need to be put to work to get as close as we can get. Yeah, I guess I'll stop rambling. And
my question will be more towards the equity, because you mentioned a Nordic paradox, let's say, because I was going to ask, whether you see those equity differences between other areas, for example, education, culture, whether there is a correlation between health inequity and other inequities such as the education, because we have also in the Czech Republic, this is what Jakub mentioned in the beginning, seemingly very equitable society regarding the access to healthcare, access to education, to other culture services and everything. But it's not. We know it's not true for many people there. So I wanted to just ask whether there's any data or your experience if the people are lower access to education, they're more likely to have lower access to healthcare services, or what kind of how those two are, because they're both publicly funded. We can influence those areas by policies. So whether there's any correlation in that regard. Thank you.
You're asking, let me just clarify, sorry, about a relationship between or more inequality in education and more inequality in health. Yes, for sure. I mean, this isn't education, but I did show that slide. Educational disparities in health are consistent across at least high-income countries. I'm not as familiar with the low-income countries context, but that's a very persistent disparity. And there is a lot of research on educational policies and the effects on health outcome, including, I think mostly in the UK, but I know there's at least one study of multiple European countries when they increased the age of how long you had to attend school for, to see if they could isolate some kind of causal effect on your health outcomes. And thinking, of course, if you are forced to get more education, then you're going to have better health outcomes. And I think, with this research, why it's so important to do more and more of it is you can look at how many health outcomes are there? There's a lot of different health outcomes. So it did vary a little bit. There was some mixed evidence in terms of that particular policy and the health effects. But in general, there's really persistent educational inequalities, as well as things like income inequality. There's a lot of research on country-level income inequality and its association with poorer health outcomes, or in the states, the U.S. states level income inequality and poorer health outcomes. And they don't only work through these access to material resource mechanisms. They're certainly an important part, but also in terms of, I'm a sociologist, sorry, but social cohesion, like I just mentioned, and being able to trust each other and feel like you're living in a safe society. So yes, there are certainly lots of correlations between those things, and I think you're exactly right that those are important levers where policies can make a big difference and a big improvement.
Thank you very much for your talk. I am from medical field and I'm dealing with the genetics, and so my question concerns on the novel treatment on rare diseases, because there are very expensive therapy for kind of muscular atrophies and so on, which cost more than several millions of dollars per one person. So do you think it's realistic to cover all the patients in different countries with such a very expensive therapy and to ensure the equal access?
Thank you so much. That's an excellent question, and that is a problem health economists struggle with a lot. Like if you have tiny population or a tiny subgroup of a population that has extremely high healthcare needs, typically even the research is not really done quite a bit on individuals who suffer from or like who have rare diseases. If there are treatments, they're extremely expensive. But at the end of the day, this is the principle of health equity, that we cannot essentially like dispose these members of society just because they had the bad luck of having a rare disease. At the same time, it's important to acknowledge that budgets are limited. and covering the most expensive treatment for a few individuals may then prevent from much larger portion of the society to receive perhaps like a cheap kind of a treatment, think of flu vaccination or something like that, that can that doesn't cost as much per individual, but when applied to a whole population can add up eventually. Ultimately, like not all of these questions can be answered by just hard data and analysis that looks only at numbers. Like at the end of the day, like there are people behind those numbers, and in these situations, I think we may just may have to make decisions based on that rather than on the pure math. Life is not black and white, and it's some of these decisions are really hard.